This is Rory Spiegel and Ryan Radecki. This is the Annals of Emergency Medicine podcast, November 2025. Ryan, how you doing?
Good. This podcast is being recorded off the grid.
Oh boy. Yes. Before we went on, Ryan showed me his solar panels.
It's my very first day of solar panels.
He is fully off the grid.
This podcast is brought to you by the sun. Yeah.
Are you guys doing like an X-Patch Thanksgiving this year?
Oh, we do something every year. Yeah. Usually we have a bouncy castle because it's like almost summer here.
But is it just for you and your family, or are you bringing a bunch of other Americans who celebrate?
There's a ton of Americans and a ton of American doctors in Christchurch and New Zealand overall. So yeah,
you all get together in bouncy castle and
they got turkeys stocked over at the shop local grocery store. Oh yeah, we can go full Thanksgiving if we really wanted to. Usually we get a turducken.
Oh, so you really go out American.
Turduckens are the best. If you're ever in Houston, there's a really great turducken place.
I'm not surprised that Houston
before we totally hijack this. I hope you're all having a safe and enjoyable Thanksgiving if this reaches you before you celebrate. Anywho, the first article we'll talk about from this issue, the November issue, is psychedelic trips travel within the United States to use psychedelic drugs after legalization. Our lead author here is Joshua Black, and they're with the Rocky Mountain Poison and Drug Safety Center. This is part research, part vacation planning, apparently, in case you're looking to mix it up and skip Disneyland this year or for something a little more mind-expanding. There's apparently a survey called the National Survey Investigating Hallucinogen Trends, and it's an internet-based online panel administered by YouGov for the purpose of learning about adults using hallucinogens. In this panel, specifically, the authors recruited individuals who had used hallucinogens over the past year, and then specifically they asked them about travel and emergency department use. In their final sample, they had 2,000 adults, 1/3 of whom reported traveling outside their home state and use of psychedelic drugs. And about equal proportions of those people who left their home state visited one of the 2 U.S. states where it is legal, Colorado and Oregon. And then another portion went outside the United States. A small number also traveled to both states or overseas or to one or both of the states. The authors go a bit into why people traveled, the reasons for use, and whether they experienced personal growth. Like Elon Musk. But the only really emergency medicine relevant mention, I would say, is the bit where they note the travelers were vastly more likely, overall, to also report having visited an emergency department during the same period. The authors suggest this means the home state for travelers may experience some bleed over from the drug use events, despite the psychedelics not being legal in their state. I think it's pretty tenuous to suggest the home state visits are necessarily related to that drug use, or specifically to that out of state drug use. But there you go.
Yeah, I think that's probably the key here, right? Like, who knows why they are more likely to visit emergency department, but obviously these people are on a journey, and sometimes that journey takes them to the ED.
For more often than not, maybe.
Why don't we move on to our next article? And that's that treatment, initiation, and outcomes associated with receipt of emergency department peer support following opiate overdose. And the lead author is Peter Treitler. So, I think we're all aware of our current opiate epidemic, and often non-lethal emergency department visits for opiate overdose are thought of as an opportunity to engage these patients in some harm reduction strategies and give them assistance when needed. And one of the tools that's often used as a peer recovery coach was essentially an individual who at a certain time in their life also had an opiate addiction problem and have now moved on to recovery. And they use their past history and knowledge and kind of experience through the system to guide our patients. And while this is something that's used throughout the country, there's very little data on how good it is and what benefits it provides. And so these authors basically thought to examine this, and they conducted a retrospective cohort study using data from 2015 to 2020, so some time ago now, using New Jersey Medicaid claims linked to the Opiate Overdose Recovery Program and ED-based peer recovery system. And they essentially looked at how often the use of the system was associated with post-discharge treatment in these patients. So the Opiate Overdose Recovery Program, or the OORP, is a statewide program in New Jersey. It provides peer delivery in the ED at the bedside, followed by 8 weeks of team-based recovery support and linkage to other services. And these authors looked at adults 18 to 64, Medicaid enrollees treated for non-fatal overdose in New Jersey emergency departments. They defined an opiate overdose as the ICD-10 code for opiate poisoning. The primary outcome was the rate of post-discharge treatment and receipt of services. So overall, they had 7,109 opiate overdose events during this period. A little over 5,400 met inclusion criteria. Of those, about 1,400 were included in the ORP service or participation, and 5,600 and some did not participate. So compared to non-participants, people that participated in the ORP were more likely to initiate out-service care after their ED visit, more likely to have psychosocial services within 60 days, and slightly fewer all ED or inpatient visits during this follow-up period. All in all, I think this is a nicely done article for what it is. Obviously, there are the normal confounders of a study like this that's not controlled. We don't know why people engaged with ORP or why they didn't, and how that affected these outcomes. But, for those of us who are trying to get more resources for peer recovery support, this is kind of a nice article to show.
Yeah, I think the key is that it is, for what it is, a retrospective propensity match study, and you don't know what's different about the people who were in the peer support cohort than the ones who weren't. They may have had different receptiveness, different support systems, there's a lot of different things that you can't measure in a retrospective sort of Medicaid claim sort of dredge like this. In theory, there's face validity to it. This is great sort of foundational research for a prospective pilot. So hopefully we'll see more work from this group in the future. The next one we'll talk about is called Clinical Experiences with the Nitazene Class of Synthetic Opioids, a Cohort Study. Our lead author here is Darren Roberts, and this is from the New South Wales Poison Information Center. For once, this one is not a you problem, it's a me problem. This is happening down here in New South Wales, Sydney, which is just a short flight away from where I am in Christchurch, New Zealand. The idea here in this report is nitazenes could be back. These are synthetic opioids first described in the 1950s, and they're good for the same general effect as other opioids, but with varying affinity and half-life. This is a data extraction from the Prescription, Recreational, and Illicit Substance Evaluation PRIZE program database, which is targeted towards collecting samples from patients who are admitted to ICUs, intubated, or require multiple escalating doses of naloxone. In the past 7 years, there were 27 laboratory-confirmed nitazene opioid exposures, the first of which occurred in 2021. From what they could tell, though, based on their limited series, the nitazene opioids didn't provide any significant additional toxicity or challenge as compared to typical opioid overdoses. Nearly all the patients taking nitazenes had polysubstance exposure and were, obviously, varying degrees of unwell, but the naloxone doses reported were in the 400 to 800 microgram range. Nothing heroic. Repeat doses were required in half of those who were not immediately intubated or otherwise sedated. So, more or less, I think this is good news, at least with this batch of drugs, that they are not obviously more dangerous than the other synthetic opioid analogs circulating.
Yeah, and in all honesty, you're not going to know what type of opioid the patient's ingested beforehand. Most of the time, you're just going to treat the toxidrome in front of you, and it's nice to know these act like most of the other opiate toxidromes in front of you.
Well, but it's nice to know if there's something circulating in your community that's of higher risk. So you're like, oh, well, they didn't respond to naloxone. It's not an opiate. Well, it turns out you actually just have to order of magnitude increase your dose because it's that great of an affinity or something like that. But if you do find, nitazenes are everywhere, don't stress.
But yeah, and these weren't even it looked like they responded to just mildly increase in your naloxone dose. Nothing like, some of those carfentanil case reports, 10 milligrams of Narcan to, get a response.
Exactly.
Yeah. Okay, moving on. Our next article, we're going to talk about delirium in older adults. This is Outcomes of Older Adults with Delirium Discharged from the Emergency Department, and the lead author is Annals Howick. So delirium, while we kind of look at it as, a mild disease where the patients are mildly confused, sometimes happily confused, sometimes agitated along with it. And we think of it as, not a life-threatening disease, but there's lots of good data that, delirium really increases the rates of mortality, of need for hospitalization, so on and so forth. And so a lot of that data comes from inpatient accounts of delirium, both on the wards and in the ICU. But this study wanted to look at what happened to patients who were diagnosed with delirium in the emergency department. And so they analyzed over 22,000 patients that were seen in the ED and were diagnosed with delirium, which was defined by the delirium triage screen and brief confusion assessment method, which are both assessments done by nurses at the bedside. And essentially, if these were positive, the patient was diagnosed with delirium. And then they broke the patients down into 4 groups: patients who were delirium positive and discharged from the ED, patients who were delirium positive and admitted to the hospital, patients who were delirium negative discharged from the ED, patients who were delirium negative and admitted to the hospital. Then they just looked at outcomes. And the outcomes they looked at were basically return ED visits or deaths within 30 days. So, like I said, overall, they looked at over 22,000 patients. Now, the patients with delirium was pretty big minority compared to those who were delirium free. So delirium positive patient discharged from DD was only 202. Delirium positive patients admitted to the hospital was only 730. This is compared delirium negative patients discharged from DD is over 1,300, and delirium negative patients admitted to the hospital over 8,000 patients. When they looked at outcomes, they essentially showed that being positive for delirium significantly increases your risk for both admission to return visits to the hospital as well as mortality. 30-day mortality rates with patients admitted with delirium positive was 13.4 and 8.4 with delirium positive patients discharged. Compare this to patients who were delirium negative admitted to the hospital was only 6%, and delirium negative patients who were discharged is 1.5%. And you see similar results in patients for ED visits. So among patients with delirium positive individuals, they had a very high rate of returning to the ED when they were discharged, 32%, compared to delirium negative patients was only 19.9%. Overall, I think this seems fairly concerning when you first look at it, but then you wonder, like, what are we going to do about this? While we know delirium is a really bad predictor of lots of badness, both in hospital and now you can see also while in the ED, we have tried for a long time to treat delirium with medications, with changing environments, and so on and so forth. And there's really been no really good studies showing we have a good way to treat this. And it's probably because you're just identifying a much more vulnerable group of patients, those who are vulnerable to delirium once they step in the hospital. They usually have more comorbidities. They usually have worse just baseline function. And I think you're more just identifying a group of patients that are far more likely to have bad outcomes rather than if you can identify and treat delirium, you'll make a difference.
Yeah, I mean it's interesting. This study was framed as like people that we admit too much delirium to the hospital. Is there a way to send more delirium home? But they never really figure out exactly which ones are the safe delirious patients to send home. And we'd all love to see that there are safe, quote unquote safe discharges for delirium. But when you like 9% of the patients with delirium that you send home are dead within 30 days, that doesn't have like safety as a face validity sort of thing. But the idea is like what is reversible, what's actually treatable, what kind of expectations and prognosis can you give the family? Are they better off at home than in the hospital? I think that's a very reasonable debate. And then or what can they do with supported discharge? Like there's a whole package of care that an integrated healthcare system can give people in their final days that keeps them out of the hospital, not necessarily extending their lives specifically, but improving the quality of the lives and improving the lives of the caregivers. A lot of these people are in the hospital because their families are too stressed and overburdened to be able to care for them safely and appropriately at home. That's one of the reasons these people get admitted, and that there's no real medical thing they're fixing, but there's a whole family social support dynamic that needs addressing to keep the patient safe. So it's a complex problem, and these data are a very superficial look at how these patients turn out, and then there's a ton of more granularity that they need to go into in future studies to determine how we're going to best use these data and use this information to change the way we treat and manage patients with delirium from the emergency department.
Yeah, yeah, and it's hard, right? Because, like anecdotal experience, like delirium only gets worse once you're in the hospital, right? When
Oh
you're
yeah.
in a novel place. But then, like, what does that really mean? Because, you're usually getting admitted to the hospital because you have some form of infection or another disease. And, how much of it is related to just being admitted to the hospital? How much of it is related to the disease burden that they have? And like you said, like, does discharge make it better or worse? And honestly, we really don't know. And
complex, multi-morbid patients who've had an acute mental status change, and you're not sure why, and you don't have all the tests and time to observe somebody in the emergency department necessarily. So you worry you're missing something reversible. And so that's why a lot of people get admitted to the hospital for that further evaluation and workup. And sometimes it's as simple as a new medication, a new exposure, or something like that. Sometimes it's infection, it's sepsis that's just not obvious in the first visit. And that's what everybody's worried about. It's figuring out exactly where the safety is, and who can go home is a very big challenge. Switching gears entirely, I'll switch to another article from this November issue called Association of Two Pre-Oxygenation Approaches with Hypoxemia During Tracheal Intubation, a Secondary Analysis. Our lead author here is Christopher Chow, and they're at the Wake Forest School of Medicine. We all know pre-oxygenation with non-invasive positive pressure ventilation is the best. However, depending on your institutional culture, it may not be an easily arranged pre-intubation adjunct. Bag valve mask is a sort of positive pressure ventilation, on the other hand, and it's usually right at hand from the head of the bed during the induction phase. But if you've ever bagged someone, and obviously we all have, you know it's not an automatic skill. It ties up at least one person just working on airway using non-invasive positive pressure ventilation as the best thing, or the old standby, a face mask. Freeze your hands up. But again, this is about life without that hands-free, non-invasive positive pressure ventilation. So these authors did a secondary analysis of the pre-oxy and device randomized trial populations, pulling out those who were pre-oxygenated with face mask oxygen versus those who received bag mask positive pressure. Owing to the characteristics and purpose of these two different trials, there were over 1,000 in the face mask oxygen cohort and only 136 in the bag valve mask cohort. And the winner was, well, it's non-invasive positive pressure ventilation that wasn't part of this trial. But the rate of periprocedural hypoxia was 15% in the face mask oxygen group, straight out of those arms in the included trials, while the bag valve mask scored also 15%. And both of those are dramatically worse than the hands-free non-invasive arm, which is about 9% hypoxia. And that's mostly from that pre-oxy trial. I think the idea is good. If you don't have, non-invasive, can we get similar results? Can we reduce the amount of hypoxia during intubation if we just use the bag valve mask? But there's no evidence in this retrospective dredge that you'll routinely get as good results with a bag valve mask. And it probably ties up some experienced hands during the process and overly complicates it. So I would suggest changing your culture to be able to supply non-invasive positive pressure ventilation as pre-oxygenation. But if you don't have that, just stick with the old standby face mask.
Yeah, so the biggest problem with this study is they didn't really record how well each of these techniques was done. So, for example, to do what we think of is optimal pre-oxygenation with a non-invasive or an oxy mask. It's that flush rate, right, where you crank the wall oxygen until it sounds like a jet engine, and you're getting somewhere between 40 and 60 liters, depending on your oxygen delivery in your hospital.
Oh,
And
but are you on face mask or airvo, high flow?
so that gives you somewhere close to nitrogen washout of an anesthesia circuit in other data we've looked at, actually in Annals on previous podcasts. And then to do it with a BVM, you're not bagging the patient. I think that's the big mistake that most people do. You're using it as a passive oxygenator. You're using their negative pressure ventilation, but you need a CPAP or a one-way valve on your exhalation port. And again, you need your flush rate turned on. And these things were recorded. And so you don't really know how well they were using these tools. And so it's really hard to compare anything here. Theoretically, a BVM with a PEEP valve would provide PEEP, which is over and above your flush rate on your non-rebreather. But only a minority of patients actually require that PEEP during pre-oxygenation. And so in a cohort like this, where there's only 100 patients who's getting the BVM, even if you did it right, would you even be able to show that benefit? So it's pretty unclear. I don't know if you can use this to do much else other than to say, like you said, non-invasive positive pressure ventilation is probably the more optimal way of doing things.
All right. What's next?
So next article is the association between out-of-hospital drug-assisted airway management approach and intubation first pass assessed by Jeffrey Jarvis. And so this study, what it's trying to look at is what is the best strategy for conducting intubation in the pre-hospital setting? And what I mean by that is, what drugs are we using? And so there's a thought that we should use our standard approach, which is RSI, a sedative, and a paralytic. There's a thought that if you are feared that you won't be able to get the airway, you don't have surgical backup, so on and forth, you should just use a sedative. And then there's a thought that these patients are already obtunded and you can use a paralytic alone, or if they're already obtunded, don't have much airway reflexes, you can pretty much use nothing. And most of the opinions and people who manage airways and the guidelines and so forth support RSI. The problem is there's not really that much data showing that RSI is better than these other forms of intubation management. And so these authors essentially conducted a retrospective study looking at the electronic medical records using a large national emergency medical service database, which contained multiple EMS agencies, over 2,700 across the United States. And they looked at over 12,000 patients who underwent at least one endotracheal intubation in the pre-hospital setting. Patients who were experiencing cardiac arrest were excluded, essentially because they wanted to make sure that they identified patients who would require RSI. A lot of times patients in cardiac arrest don't actually require RSI, so they didn't want to bias the study because of that. And then they basically divided this group into four cohorts: people who got rapid sequence intubation, which is a sedative and a paralytic, sedative alone, paralytic alone, and no medications. Again, they analyzed over 12,700 patients. The majority, 51.2%, had rapid sequence intubation done. 29.6% had no medications, 17.9 sedative only, and 1.3, so a small minority, had paralytic alone. Overall, first pass success was around 75.1%, which is fairly in line with pre-hospital studies we've done before. The primary tool, 42.6%, was video laryngoscopy. If we look at first pass success in each of the groups, rapid sequence intubation was the winner at 82.4%. Paralytic alone came up fairly similar at 82.0%. And then sedative only and no medications were far behind at 67.6 and 66.8% respectively. And obviously, when they looked at this using regression analysis, they found that rapid sequence intubation performed far better than sedative alone or no medication intubations. And it was associated at a much higher rate of first pass success. So there's obviously a number of limitations in this study. In the editorial by Carlson et al. That was accompanying this, they basically talk about the limitations of first pass success and question whether it really is a patient-oriented outcome. They discuss how it doesn't really fully capture what we want to assess when we're assessing quality in intubation. For example, you can actually have first pass success and the patient can still arrest on you because of hypoxia, because you never took the blade out of the mouth before you got the tube in. A lot of other stuff can happen that we don't think is optimal, and first pass success still can be relatively high. I think there are some limitations with the metric of first pass success. I don't really think that's the biggest issue with this study. The biggest issue, it's uncontrolled. It's really unclear why certain patients received certain drugs and other patients didn't. It's entirely possible that patients who received sedation only or no medication were thought of as more difficult airways, and the providers were worried about paralyzing the patient and being unable to intubate them. And so they just use a sedative alone. And obviously, this is a very different patient than it would be if someone felt fairly confident and did a standard RSI. And so I agree with their conclusion. I think for the majority of our patients, we should be using sedative and a paralytic. I'm just not sure how much more evidence this study provides to support that statement.
Yeah, I mean, RSI is, a very nicely controlled situation for intubation. The other things are precarious at best. When I was in training, we had our local paramedic services weren't allowed to RSI, so anybody who required an airway got sedation, if anything. So I think there's a lot. They do try to control for agency, level factors, but we don't really know why these patients are getting non-RSI intubation, what the skill level of those specific operators is, what they're licensed to do, and all those little granular features that also go into first pass success. All right, I think last article maybe. Yeah, here we go. Stroke sensitivity calculation and medical emergency calls and factors associated with stroke suspicion, a retrospective registry-based study. Our lead author is Emil Iverson, and they are with the Norwegian National Advisory Unit on Emergency Medical Communication. It's an AI article. For a while, it felt as though we were getting a machine learning article every week, but it's also not an AI article. This is an AI training article. It's a brief report regarding the laborious manual cleaning of a dataset. In this specific case, these articles are trying to improve early stroke identification for EMS dispatchers in order to properly prioritize calls, speed of response, and potentially the level of care required. This is all part of an umbrella project called the Artificial Intelligence Support in Medical Emergency Calls. The purpose of this article was to see whether the current data set fully captured whether a dispatcher suspected a stroke just based on the coded data rather than in the free written text, or whether another variable needed to be created on top of the coded data to improve sensitivity for stroke suspicion when they're doing their leg training. So effectively, the authors targeted the subgroup where there was a clear suspicion of stroke, but it wasn't explicitly coded, and then used the rest of the available coded variables captured to try and predict where those instances occurred. They termed this the stroke variable, and they added it to the regular stroke suspicion, and this improved identification of when a dispatcher actually suspected a stroke. So this is very bespoke, and I'm not entirely certain whether this is a generalizable approach to this sort of data cleaning, but mostly it just demonstrates some of our fundamental problems in machine learning and artificial intelligence. Garbage in, garbage out. Finding accurate ways to spruce up your data before ingestion, the so-called data cleaning phase, are far more important than appreciated by those not in this space.
It took me a while to figure out what to make of this study. And I mean, obviously everyone in this study had a stroke, so you can only calculate the sensitivities and not the specificity of what their actions are doing. But like you said, otherwise, I think this is mostly related to how we look at data rather than, how it actually helps patients.
Yeah, it's an artificial intelligence data cleaning study. Sometimes the coded information doesn't accurately represent the actual clinical scenario, which we have known for a million years. But a lot of people, when they do these big retrospective data dredges, and when they're just pulling out, ICD-10 codes, and they're pulling out whatever, CPT, whatever it is, these for lots of the studies that we review here, that's the coded data. It's not necessarily reflective of all the clinical nuance that goes into the case.
All right. Well, I think that wraps us up for another month. Ryan, I hope you enjoy your bouncy castle in Turducken in the middle of the summer.
I hope you all enjoy a weather-free travel day.
Otherwise, until next month, this was Rory Spiegel and Ryan Radecki, and this was the Annals of Emergency Medicine podcast.